Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Coughing Up Answers, What is Causing Your Chronic Cough? It's my pleasure to introduce our speaker, Lauren Eggert. Dr. Eggert is a board-certified, fellowship-trained pulmonologist and a clinical assistant professor in the Division of Pulmonary, Allergy, and Critical Care Medicine at Stanford University School of Medicine. She's an expert in the diagnosis and management of diseases of the airway with a focus on patients with allergic asthma. She also treats chronic obstructive pulmonary disease, COPD, and ABPA and chronic cough. Throughout the talk, please enter any questions into the Q&A box at the bottom of your screen, and at the end of the talk, Dr. Eggert will answer as many of those as possible. Over to you, Dr. Eggert.
Well, thank you again so much for having me today. I'm very excited to be here today to talk to you about something that I see a lot in practice, and I think which is chronic cough. And yes, really excited to share some of that information with you today. So let me just share my slides and we'll get started. So today we're going to talk about coughing up answers. What is causing your chronic cough? And so how we're going to do this is first we'll talk about the epidemiology of chronic cough and how we define chronic cough. Then we'll talk about the most common causes of chronic cough, and I'll kind of work you through how I treat them. I will go through the diagnostic evaluation and kind of algorithmic approach to treating chronic cough. And then we'll spend a little bit of time at the end talking about a specific entity, otherwise known as refractory chronic cough and unexplained chronic cough, which are a separate entity and treated a little bit differently. So first, how do we define chronic cough? So chronic cough is any cough lasting longer than 8 weeks. An acute cough is less than 3 weeks. It's usually due to an acute illness. Right now, I've been in the hospital a lot frequently, and there's a lot of flu going around, a lot of RSV, respiratory syncytial virus, and any kind of lower respiratory tract illness can cause coughing. Usually, though, when the illness gets better, that goes away. Then there's subacute cough, which generally lasts anywhere from 3 to 6, sometimes 8 weeks. The most common cause for that is post-viral cough. Other reasons could be a post-viral reactive airways or asthma type reaction, or pertussis or whooping cough, which is much less frequent these days in the era of vaccination. But then once you get to chronic cough, anytime more than 8 weeks or 2 months, we define that as chronic cough, and we look at that a little bit differently. So chronic cough is very common. It probably affects about 10 to 12% of the population. It's similar to the prevalence of asthma among the population. It varies geographically, as you can see here. As I mentioned, about 10 to 12% of the population in the US, but there's definitely areas, as you can see, like Australia here, where the prevalence is even higher. Females, we don't know if chronic cough is more common in females or if they're more likely to just seek medical attention, but we see chronic cough more frequently in females, probably in about a 2-to-1 ratio. And the most common time that chronic cough presents is in the 5th and 6th decade, although it can present at any time. And I definitely have patients spanning the spectrum of ages. So what causes chronic cough? Probably about 90% of chronic cough without red flag symptoms is due to the causes listed on the left here. And those causes are primarily diseases of the airway, like asthma or chronic obstructive pulmonary disease, COPD, GERD, which is another name for gastroesophageal reflux disease, medications, most specifically ACE inhibitors like lisinopril, and then rhinitis or postnasal drip, something we call upper airway cough syndrome. Less common causes of chronic cough that we see and that you always want to make sure you rule out are lung cancer, non-asthmatic eosinophilic bronchitis, which is a condition where you have eosinophilic inflammation in the airways without bronchoconstriction, which is what differentiates it from asthma. Sometimes occult infections can cause cough. Occult microaspiration or chronic aspiration when food goes down the wrong pipe. Inhaled foreign bodies, although I must say this is much more common in children and not seen very frequently in adults. Laryngeal hypersensitivity, which we'll talk about a little bit more later. interstitial lung diseases, and some other rare causes, like even very frequent premature ventricular complexes or PVCs, which is a heart arrhythmia, can cause coughing due to nerve innervation and irritation of the nerves. So, talking about asthma and chronic cough, asthma is one of the most common causes of chronic cough. And when I'm assessing a patient for asthma, I look at their symptoms. Usually, asthma and chronic cough, there are symptoms of wheezing and dyspnea, but sometimes it really can just be cough. Features in the history include a personal history of atopy, which means like different seasonal allergies or allergic history, a history of eczema or food allergies, seasonality, symptoms that are worse different times of the year because cold air can trigger asthma, and different allergies have different seasonality. If you're allergic to trees, your symptoms may be worse here in California in the spring. Often what I hear is that patients will say, my whole family got a cold and they were sick for a week, but it's been 4 to 6 weeks and I'm still coughing. That's pretty suggestive of asthma. Worsening in response to specific triggers, and then again, shortness of breath or wheezing. How we diagnose asthma is first and foremost, I always do a spirometry or a breathing test. And in a spirometry, you breathe, we have you blow into a tube as hard as you can, and we look to see if you have trouble getting air out and whether or not it gets better with albuterol, which is a medication that opens up the airways. And having trouble getting air out that gets better with albuterol is suggestive of asthma. But however, one normal breathing test doesn't rule out asthma because by definition, it's a disease of reversibility. So sometimes we have to go a little bit further and do provocative tests like a methacholine where actually irritate the airways to make the diagnosis of asthma. And really the best way to show that asthma is causing someone's chronic cough is to treat them for asthma, primarily with inhaled corticosteroid containing inhalers, and show that they improve, the cough improves. And so, looking at some of the guidelines that have been put out on how do you treat chronic cough due to asthma, again, the main recommendation is a short term trial, so about 2 to 4 weeks of a moderate to high dose inhaled corticosteroid to see if this will help with the cough. And then, as I'll say, a lot of things with chronic cough, a lot of it is trial and error. So for asthma, oftentimes, I'll try to do the testing, I'll do the spirometry, and then we'll try the inhaler and we'll see if it helps. But I think what's important that as you go on, we don't want to just keep adding therapies. We want to make sure we discontinue therapies that aren't working. So we'll give it a trial of inhaler, and if it's not working, we stop the inhaler and we kind of go on to the next step. So let's talk about the second most, or one of the other most common causes of chronic cough, which is gastroesophageal reflux disease. And we think that GERD probably causes a chronic cough through direct stimulation of these afferent sensory nerves in the larynx that get very irritated by the refluxate, which can be non-acid material, and the acid coming up from the esophagus. There also may be a component of microaspirated gastric contents stimulating receptors in the lower airways. And how do we find out if GERD is contributing to a chronic cough? Well, we look for clues in the history, and I will talk about later how there are definitely certain factors in the history that can point you one way or the other. Actually having acid reflux symptoms is probably the most suggestive. Worse when you first lay down at night because your sphincter relaxes, or cough, that's worse after meals. But to really diagnose GERD and say, see if it has a relation with cough, there's some additional testing you can do. We'll start often with a barium swallow. Looking at your swallowing, it's a screening test for your esophageal motility to see if there's any problems there or any structural problems impeding your swallowing. One of the tests I do more frequently that can be more helpful actually is 24-hour pH monitoring, where actually during an EGD or an upper endoscopy of your esophagus, they leave a probe down there and they can leave it in for a day or a few days. And they actually look at how many reflux events there are. And you can also have the patient report their symptoms. and both see if there's reflux, number one, but also if it correlates to symptoms. So sometimes, we'll find reflux, but the reflux events aren't correlating with the patient's cough, and then the cough is probably not due to the reflux, even though it's there. This is a pretty invasive test. Like I mentioned, you have to go to a gastroenterologist, you have to get an endoscopy, they have to leave a probe in. So generally, this is reserved after an empiric trial of a proton pump inhibitor, like over-the-counter omeprazole or Protonix I use very frequently, just to see if an empiric trial of controlling the acid will help with the cough. And then if we're still not sure, there may be a role for this additional testing. Other tests that are esophageal manometry, which is kind of looking if there's dysmotility problems in your esophagus, which we sometimes see and is sometimes indicated. Um, that's more sensitive for reflux and dysmotility. And so how do we treat cough from GERD and reflux? Well, there's limited evidence for proton pump inhibitors, like I mentioned, or pro-motility agents in the absence of symptoms. But in general, we do try them because it's a very low risk intervention. They're readily available over the counter. There's very few short-term adverse events, again, with short-term use. Many of the, adverse events have been linked to longer-term use, like atypical long bone fractures or possibly a, higher risks of osteoporosis or with long-term use. These drugs block acid production, relieve acid-related symptoms, but unfortunately, they don't affect the volume of non-acid refluxate. And we don't know if the cough is due to just acid or just reflux in and of itself irritating the nerves. So we often like to combine this with a trial of lifestyle modifications, kind of reflux and aspiration precautions, which I discuss with all my patients. Avoid triggering foods. Most commonly, that's peppermint, caffeine, chocolate. I know, right? All the good things, pizza, acidic foods, citrus. But many people know, what triggers them or what's bothersome. I ask everybody to avoid eating a few hours before bed, so contents aren't as likely to reflux up the lower esophageal sphincter, and to consider sleeping at an angle. And these two things together, I'll often try, especially if there's a suggestion that the symptoms or the cough might be related to reflux. And again, if it's not working, you try it for 6 months or 2 months, or sorry, 6 weeks or 2 months. And if it's not working, we don't continue these medications and we go on to the next. But let's talk about LPR, or laryngopharyngeal reflux. So I mentioned that GERD is a problem with the lower esophageal sphincter. LPR is a problem with the upper esophageal sphincter. So it's the retrograde movement of gastric contents into the laryngopharynx that's leading to symptoms. And unlike heartburn, many patients are unaware of this phenomenon. Only about 35% with this actually report heartburn. And really the only way to diagnose this is through direct laryngoscopic evaluation by an ENT doctor, where they actually go in there with a scope and take a look. You'll often see a lot of arytenoid erythema and edema. You can see pharyngeal inflammation, and these things are often suggestive of LPR, although it can be hard to tell GERD versus LPR just when looking at the vocal cords. But you can see here in panel A, those are normal vocal cords. And on the right, you can see how swollen these arytenoids are and all this pharyngeal erythema. The typical symptoms you may feel if you have LPR would be dysphonia, which are voice changes, including hoarseness. Chronic cough is frequently seen. There may be mild trouble swallowing or a feeling like there's a ball or something in your throat, and often non-productive throat clearing. So how do we treat LPR? Well, one of the most commonly used treatments for LPR are alginates. So unlike antacids, like we talked about before, proton pump inhibitors, which work by reducing acid production, or antacids, which actually counteract and neutralize the acid, alginates here in this middle panel, you can see they form a raft that floats on top of the stomach contents and prevents them from going upward. And some products contain antacids combined with this to kind of attack both ends. And there's currently 7 products available, all are over the counter. Most of them you can get on Amazon. You can see here Gaviscon, Max Relief, and Reflux Gourmet over here on the right are some of the most popular. I have patients take them after dinner and before bed. And sometimes a trial of those can be very helpful and is very frequently used by both myself and our ear, nose, and throat doctors involved with chronic cough here. So let's get to the third most common cause of chronic cough, which is upper airway cough syndrome. So this upper airway cough syndrome is when you have a cough that's due to postnasal drip or nasal secretions that flow into the posterior oropharynx, the back of your throat, which can be caused by either allergic, perennial non-allergic, or vasomotor rhinitis, which are just really fancy ways of saying there can be a lot of reasons that you have postnasal drip, although often they're frequently treated similarly. These secretions, similar to the reflux in GERD, probably trigger those cough receptors in the larynx and upper respiratory tract when you have that dripping come down. People will often report feelings of nasal discharge, feeling like liquid is dripping back in their throat, frequent throat clearing. And what I hear a lot is cough that's worse first thing in the morning. And that's because when you're sleeping and you're supine on your back, all those secretions are flowing from the back of your nose into the back of your throat. And then you wake up and you've kind of got to clear them all out first thing in the morning. So that's something, a common piece of history I'll hear. Many people also just feel the secretions in the back of their throat. Um, I can often see them when I look at patients. Everyone with a chronic cough, I look in the back of their mouth with a light. And if patients have chronic allergic rhinitis, you'll often see cobblestoning of the mucosa in the back of the mouth. And I'll often see a lot of secretions, often clear foamy secretions in the back of the mouth. And that can be a hint that there's ongoing postnasal drip. Unfortunately, for upper airway cough syndrome, there's no gold standard diagnostic criteria, but some ancillary testing that can be helpful are kind of sinus imaging or allergy testing. But often that's not done unless an empiric trial of therapy fails, again, because therapy is pretty benign and is often very helpful. So, how do we treat upper airway cough syndrome? So, no matter what the reason for the postnasal drip, first line therapy is always a steroid nasal spray. This is the most effective therapy for allergic rhinitis, and it's basically the only option as well for non allergic and vasomotor rhinitis as a first line therapy. It's recommended by most guidelines as the best single therapy for patients with persistent symptoms, including seasonal symptoms. And just a note, there's a lot of preparations available over the counter now. Nasacort, Nasonex, Rhinocort, Flonase, Flonase Sensimist. They all have a different steroid in them. None of them are more effective than another. So I can't really recommend one or over another. Some people prefer one over the other, one over another. Flonase is alcohol based. It tends to be a little more drying and irritating. But any of the non-alcohol based ones, a lot of people tolerate better, and I really have no preference. Then, if ongoing symptoms despite intranasal steroids, we often add a second agent. Usually, I prefer a nasal antihistamine. Again, these are over the counter and include things like azolastine, which for over the counter names would be Astelin or Astapro. Or we'll often use oral second generation antihistamines like Zyrtec or Allegra. Things I like to make sure that I talk to my patients about when we're treating upper airway cough syndrome is just make sure you know how to use your nasal sprays. So, when you're using a nasal spray, you want to make sure you point it, you want to first chin to chest, you want to point it up and out. The delicate blood vessels run along the septum of your nose. And if you're putting an irritating agent and putting it up your septum, you're much higher risk of having nosebleeds, which are going to make you not be able to tolerate therapy. And also the turbinates, which you're trying to reach, go out this way. You want to put it up and out, gentle sniff, spray, gentle sniff. None of this, because then it's just going to go down the back of your throat and you're not going to get the medicine to stay where it needs to be. Also, if you're someone who uses nasal rinses to kind of rinse out the allergens in your nose, make sure you wait at least 45 minutes to an hour so that your nose isn't dripping still before you put the sprays in. And what I can't stress enough is make sure you do an adequate trial of use. So, a lot of patients will use a nasal steroid for a day or two and say it did nothing. Well, it's not like Afrin. It's not going to give you that immediate relief. It's a steroid, so it's going to decrease inflammation, but it takes a little bit of time. And it might take time for the symptoms to get better even after that inflammation starts going down. So I tell everybody to do at least 2 to 4 weeks, maybe even 4 to 6 weeks if there's some equivocal benefit, just to make sure you're giving it an adequate chance to work to see if it helps with the cough. Sometimes there's also persistent dripping despite all of this that's contributing to the cough, and I will add Atrovent nasal spray, which is a drying agent that kind of dries up your secretions. There's some evidence for that also for use in the chronic cold, common cold. And if patients have a lot of benefit from those kind of that drying nasal spray, there's something ear, nose, and throat doctors can do called cryoablation of the posterior nasal nerve. Oops, that can help with that constant dripping. Um, and so going back, I've talked about the most common causes of chronic cough and a basic approach to treatment. So, how do I approach the patients who come to my clinic with chronic cough? Well, like I mentioned, the first thing I do is rule out red flag symptoms or history items. And actually, I'm going to jump ahead to go through that because I think that's right here. Then I'll go back. So, what are these red flag symptoms, and when should you be worried that your cough might be something more serious? So things that I always think about that would worry me would be what we call B symptoms. So these are systemic symptoms that suggest some kind of full body process, and that's unintentional weight loss, because otherwise, that's not very common. Night sweats, and a lot of people sweat at night, but I mean soaking the sheets, like having to change your clothes, and fevers. Um, Hemoptysis or coughing up blood would be something that would be concerning to me for that this is not just, a chronic cough that's benign, that's something we need to work up a little bit further. Um, Virulent sputum, so thick sputum that's white or green or pus, especially in a former smoker, really worry, makes me want to investigate, sooner and a little bit more intensely into pulmonary causes. Anyone who's immunosuppressed, that means somebody who's on chronic steroids, somebody who's on immunosuppressive drugs for a chronic condition like lupus or rheumatoid arthritis, somebody who's undergoing chemotherapy, or any kind of patient who's had any kind of transplant, whether it be liquid or solid, just because of the much higher risk of infections, including atypical and indolent infections in these patients. And then anybody with any kind of acquired or congenital immune deficiency, again, because of the risk of infection. And then something I don't have here is anyone with a personal or family history of lung cancer. Um, I want to make sure that I'm, getting imaging right away to rule out any lung cancer. So once I've ruled out all those red flag symptoms and I don't need to, rush right to get a CAT scan and, make sure that, not worried there's something more serious going on, then I really do a detailed history and physical exam to really decide on what I think the most likely cause of the chronic cough is out of those things we discussed: GERD, LPR, upper airway cough syndrome, or asthma. I then do go through an empiric stepwise treatment and evaluation of those most common causes of chronic cough, ensuring adequate trials of therapy. And again, very important, making sure I'm discontinuing any unsuccessful therapies. So we're not just, adding up therapies. I order appropriate and stepwise ancillary testing, like the pH testing, spirometry, methacholine challenge, allergy testing, sinus CTs, and then order specialty referrals based on those most likely causes, including GI, ENT, or other. So when I talk about how do I decide what I'm going to do first and why it's so important to take a real detailed history, is because there are clinical features that a patient will tell you that can be very helpful with determining the cause of chronic cough. So this was a study from a few years ago that looked at patients who finally were diagnosed with chronic cough of a specific etiology and then looked back to see what in their history helped predict the cause of that cough. And so I will say that nocturnal cough, and specifically as you can see here in the second row, nocturnal cough alone, so a cough that wakes you up at night, is quite specific for asthma. So it's not sensitive, which means not everybody's going to report it. But for those who do, they say, I wake up at night with a cough. It wakes me up from sleep. That's highly suggestive of asthma. So I always ask about that. There's not many other things that will wake you up at night with cough. Cough after meals, heartburn, or reflux symptoms. Again, not very sensitive. Not everybody's going to report those, but when you have them, they're very suggestive of a cough from GERD. And then a history of sinusitis and that actual feeling of postnasal drip, again, very good at suggesting that upper airway cough syndrome is the cause. Rhinitis, actually reporting like symptoms in your sinuses, and is actually quite sensitive as well. Most people who have cough related to the sinuses will have sinus symptoms. So here is an algorithm that's been published, a kind of one of them. There are very many, but I picked this one because I liked it. About how, kind of a more algorithmic approach to chronic cough, which is again, any cough lasting greater than 8 weeks. And again, they say, first thing is that history and physical exam focused on the cough characteristics and triggers to determine the most likely cause, as well as, basic imaging with a chest x-ray and that spirometry. And sometimes fractional exhaled nitric oxide. Actually, I didn't mention that. That's something I do frequently. It helps you tell if there's eosinophilic inflammation at the lungs and can be suggestive of asthma. It's a very easy test. You kind of put these together and say, with these tests you have and with the history and the exam, is there an obvious pulmonary cause or extrapulmonary cause, which would be upper airway cough or GERD for this cough? And if so, you manage it according to guidelines, and that's it. If not, you kind of do all that additional testing we talked about, you review them, and keep trying to work through the different testing to evaluate for the different causes of cough. When you're out of luck, when you've done everything and treated everything and the cough's still going, that's when you come up with this category that we'll spend the last talking about, which is refractory chronic cough or unexplained chronic cough. So what is refractory chronic cough and unexplained chronic cough? So if you see here on the left, this is the diagnostic funnel, which kind of is the US prevalence on the top of chronic cough. They're saying 5% here from where they pulled this slide, but we said in the beginning could be as high as 10 to 15%. And this is that cough lasting greater than 8 weeks. Then you kind of funnel that down and you assess for those causes we talked about: asthma, upper airway cough, GERD, non-asthmatic eosinophilic bronchitis. You treat for those, and so then that gets rid of another big portion of patients. But at the end, there's going to be about 5 to 10% of those 5% of the US population that you started with chronic cough that have a cough that you can't explain. And it's either refractory chronic cough or unexplained chronic cough. They're both treated the same, but they're defined slightly differently. Refractory chronic cough is kind of, you found an underlying cause like asthma or postnasal drip, but you've treated it as best you can and the cough persists. Unexplained chronic cough is when you investigate and do all your investigations, you try all your therapies, but you don't find any problem and the patient is still coughing. And then it's just idiopathic or totally unexplained. And again, this all again only applies to your patients who are non-smokers and who don't have any of those red flag syndrome symptoms and have a chest x-ray that's normal. So Refractory chronic cough or unexplained chronic cough are now considered to be kind of an entity of their own, very common, a lot of disability, um, a lot of healthcare dollars spent on these patients. And so there's a lot of research and study going into understanding these patients more. So for these patients, they probably make up about 20 to 46% of patients that go to see a specialist for their cough. So probably, almost the majority of patients who go to a specialist have an unexplained or refractory chronic cough. These are the patients where that cough's usually been going on for at least a year. Sometimes, I see patients who've been coughing for 30, 40 years at this point, and that's generally already pointing me towards this diagnosis. Um, Really, the cough is usually dry. Sometimes it's minimally productive, although I do have to say a lot of patients tell me they feel so much mucus. They have so much mucus, but they don't cough it up. But often it's just a sensation. And even though you feel the mucus, when we actually scope you and look at the larynx, there's no mucus there. And it's just a laryngeal or a nerve hypersensitivity. Um, and again, other features that kind of point to this diagnosis are that globus sensation or feeling like there's something stuck in your throat, voice changes, often triggered by talking, laughing, or temperature changes, or this recurrent tickle in the throat or urge to cough. So I think that knowing that, let's talk just very briefly a little bit more about cough because it's actually a fascinating and very complicated thing. So cough happens when the pattern of normal breathing is just temporarily altered to allow for a forceful expiration of air. And, this serves a very normal purpose and it's, helped us, helps us survive. Because if foreign materials get in your airways, if chemicals are sprayed in your face, or if there's secretions, you need to clear them from the airways so you don't get pneumonia, so you don't, suffocate and die. So coughing is normal to expel things from the airway. Um, and it's a reflex in some ways. Like if you touch a hot stove, it's a spinal reflex. You just withdraw and you don't have any put any thought into it. It just happens. And cough is the same. You have a cough reflex where if somebody again sprays pepper in your face, you cough and you don't have anything to say in it. It's just a reflex. But it can also be a volitional act without any peripheral sensory stimuli, you can make yourself cough. I can make myself cough. So it's not just a involuntary reflex. There's much more to it. And you can also exert voluntary control to change the intensity of your cough or to suppress your cough. Like I'll talk about this in a minute, but one of the best treatments for chronic cough is actually cough suppression therapy, where we teach you, not me, but our wonderful speech therapist, actually how to, when you get the urge to cough, how to suppress it. And over time, suppressing that, the nerves get a little less angry and can heal and they aren't so oversensitive. And I'm not going to explain this slide. There's way too much here, but this is just to talk about how complicated this cough reflex is, all the different afferent sensory inputs. You have inputs from peripherally, in the airways, in the actual lungs, in the larynx, in the esophagus, that can initiate that cough reflex. And there's also multiple control centers in the brain, and there's different chemicals in an ATP dependent pathway and in a non ATP dependent pathway that can carry out this reflex. And so, why do we think this happens? So, usually somebody ends up with chronic refractory cough or chronic idiopathic cough because they have that normal cough response to a virus like the flu or a cold, or they have seasonal allergies, so they're coughing. But for some reason, the virus goes away, the allergen goes away, but the brain perception or the nerves keep or stay irritated and stay oversensitized. And so the urge to cough increases. And then the brain center is more hypersensitive. And then all this together, you just have this urge to keep coughing that's now become a nerve phenomenon that's taken over from the initial inciting factor. And that's when you end up with this chronic neurogenic cough and these chronic prolonged coughing fits, and it just can keep getting worse and worse. Um, and I really like this graphic on the right, and I kind of like these terms because I think they're kind of important ones we use when addressing cough hypersensitivity. So two things we really see are this cough, are allotussia and hypertussia. So allotussia is when you have, become hypersensitive and you have this hypersensitive response to non-tussive stimuli, which means, non-cough evoking stimuli. So something that shouldn't normally make a person cough, all of a sudden these people are very sensitive and will cough to the stimuli they shouldn't cough to. And that can be often is cold air, fatigue, stress, and even a lot of times I hear like even singing or talking bring on the cough. And these are not noxious stimuli that should cause a cough. The other thing we see is hypertussia, and this has been proven in studies where they give capsaicin or other irritants to the airway and see in these patients with these hypersensitive nerves that cough is triggered by smaller amounts of stimuli, like irritant stimuli, than it would normally take to cause a cough in a normal person. So that's like pollution, allergens, and other things. And like I said, the thing we test it with is actually capsaicin, a pepper, because you should cough to that, but only at a certain threshold. And people who develop this cough hypersensitivity, well, their threshold will become much lower. And, just to recap again, one of the things people will feel is often irritation in the throat or upper chest, often, but not always, can be pinpointed to the throat. And you get often these cough paroxysms that are very difficult to control and just all sorts of different triggers, like you can see here. Aerosols, cleaning products, lying down, eating, exercise, almost anything can end up triggering the cough. And this actually used to be called a psychogenic cough, which kind of made it sound like it was, all in somebody's head. But like I've mentioned, we now know that's really not the case. It's actually a nerve problem. And that's why I love this study from 2021, where they actually measured the airway sensory nerve density and complexity in patients with and without chronic cough. And they actually found that in a biopsy of somebody's airway, that the sensory nerves that take in those sensory inputs actually had increased length and branching in chronic cough patients compared to just healthy controls who don't cough. And this really shows that it's actually a nerve problem. Your nerves are actually remodeling when you're coughing so much and changing, your threshold to different cough triggers and, making your nerves so sensitive that your coughing even responds to these non-noxious stimuli. So now that we kind of understand better that this is actually a nerve problem, a lot of the treatment is kind of focused on addressing that nerve hypersensitivity. And the most common things we use, and I just want to preface this by saying I'm going to speak to this from a pulmonologist perspective. Actually, I do a lot of this treatment, but many pulmonologists will refer to our colleagues, the ear, nose, and throat doctors, the otolaryngologists for this issue. Actually, we have many wonderful ENT at Stanford who specialize in laryngeal hypersensitivity and this chronic unexplained cough that run big clinics with specialized speech therapists. And so, they may explain this information differently, but, this is just my pulmonology perspective on this. But the main treatments for chronic or unexplained refractory cough include the triad of speech therapy, neuropathic agents, and sublingual nerve blocks. And often, a combination of these therapies is superior to one alone. Um, and so speech therapy is very important, as I mentioned, for chronic cough and excessive throat clearing. Really helps you control that urge to cough. And there's been two randomized control trials, at least randomizing patients to speech therapy versus placebo. and that they showed improvement in cough severity and frequency. Also, things that have been noted in these studies are patients end up with a greater sense of control in managing their cough and their cough triggers. And most of the guidelines from the major respiratory societies suggest a trial of cough suppression therapy or speech therapy for chronic refractory cough. And as I mentioned, there is evidence that combining this with a neuromodulator may enhance the treatment effect of both. And what does speech therapy for cough suppression look like? It's kind of a combination of education, vocal hygiene, cough control suppression training, and behavior modifications to kind of reduce the over-awareness of the need to cough. So when we look at neuropathic agents, the three main agents that are used and have some data are gabapentin, amitriptyline, and pregabalin. So this was kind of a sentinel study from 2012 that looked at adults with refractory chronic cough who had no known respiratory disease and gave them up to 1,800 milligrams a day of gabapentin, which is a 3 times a day drug, so 600 3 times a day. And they looked at their cough quality of life, which is this LCQ score. Um, and they saw that gabapentin significantly improved cough specific quality of life. That being said, and you can see here, this is the cough severity score. The red one is the gabapentin group. And there was a higher score, which is better in the gabapentin group. This is the cough severity in the second bottom left panel. That was significantly lower at the end of treatment. The dotted line at the end is the end of treatment. You can see that the red group, there was decreased cough severity that was statistically significant in the gabapentin group, less cough frequency, this top panel on the right, but not much difference in the CR5. So that being said, it's a 3 times a day drug. Uh, there's a lot of side effects like nausea and fatigue, and I have had a lot of trouble getting patients to tolerate the doses of gabapentin needed to control their cough. So that's why there's some interest in other neuropathic agents. There's pretty good data for amitriptyline, and that's probably the one I use most frequently. I've had the best luck with. Most patients don't need very high doses. As you could see here, most patients needed somewhere between 10 to 40 milligrams, which is fairly low dose. And all of them are, 67% on amitriptyline at 3 months after starting, even on these fairly low doses, had a greater than 50% improvement in cough, and 92% had any improvement in cough, with about 17% having side effects. And pregabalin, actually, this was actually only looked at as pregabalin combined with speech therapy and compared to speech therapy plus placebo. And there was a significant improvement in those cough questionnaire scores and improvement in cough severity that was statistically significant when pregabalin was combined with speech therapy versus just the speech therapy alone. And one of the newer therapies that we're using a lot at Stanford, and I'm about to finish up, are these sublingual nerve blocks. So again, I'm not a ENT doctor, but what they do is they percutaneously, so through the skin, will put some lidocaine, which is a numbing agent, and some steroid, which is an anti-inflammatory, into around the sublingual nerve to kind of calm it down. And there's pretty good data. This is actually a randomized control trial that's cited here, that if you can look at this big panel on the bottom, that VAS score, that cough severity score, was statistically significantly improved even out to 3 weeks after the first sublingual nerve injection. And this is not even, some of these patients were already on neuropathic agents and things, but it wasn't, necessarily combined with all of the speech therapy and the neuropathic agents. The thing is, sometimes these can take several treatments. The doctors will often reevaluate and see if another one is indicated. And if they work, sometimes they might be needed even as much as every 3 months. But in general, at least in the studies, there's really no significant adverse effects. So that's all what I had to say today. And now I think we will open it up and have a little bit of time for questions.
Thank you. Here are a few questions from chat. Can you explain what was meant when you said PPI doesn't affect the volume of reflux events?
Yes. So PPI, proton pump inhibitor, stops acid formation. And so it's only affecting the acid, but we know that people reflux more than just acid. Gastric contents, other gastric juices get aspirated and can cause chronic cough. So by using a PPI, you're just addressing the acid component of the reflux. So it may be helpful if that's a major component, but it won't be helpful. And again, lifestyle modifications will probably be more helpful if it's other gastric contents that are causing most of the reflux.
Thank you. Does dairy contribute to congestion?
Not that I know of. I think for some people it may, but there's no good evidence, at least in my practice, that or of any evidence that I know of, that dairy is a huge factor in terms of chronic cough or causing any type of congestion.
Does the vagus nerve have anything to do with chronic cough?
It can. Vagus nerve is definitely one that can become irritated and hypersensitive in chronic cough.
Is budesonide inhalation effective for rhinitis?
Well, inhalation means taking it, inhaling it. I think there's less evidence for that. I frequently will use budesonide in a sinus rinse for chronic rhinosinusitis, which is like a chronic sinusitis that's deeper in the sinuses that's causing problems. I will use, and many of our sinus doctors here will use budesonide in sinus rinses, and that can definitely be very helpful and really help control inflammation in the sinuses. And so, very helpful if cough is due to that chronic sinusitis.
Are expectorants for sputum and chest useful?
Expectorants, and what was the second one?
For sputum in chest?
Oh, uh, there's mixed evidence on the use of expectorants. So I think what we're talking about is mostly, what's in over-the-counter cough medicines like Robitussin or guaifenesin and dextromethorphan. Guaifenesin is considered more of an expectorant, dextromethorphan more of a cough suppressant, although they're fairly weak. There is some minimal evidence for guaifenesin as an expectorant. Theoretically, it should thin the mucus out a little bit. If a patient has, especially in COPD with chronic bronchitis, a lot of mucus, I will have a very low threshold to try over-the-counter Robitussin or something similar with guaifenesin as an expectorant. But I don't think it's often like the magic bullet or the evidence is pretty limited. But it's again, for like I'll say for a lot of these things, it's very benign without much risk. So it can be worth trying.
What is the treatment for chronic nasal drip?
Chronic nasal drip, like I mentioned, the first line therapy for that is intranasal steroids. And then you can add Astelin, which is a topical antihistamine spray, or an over the counter antihistamine like Zyrtec or Allegra. Sometimes, if, especially for vasomotor rhinitis or rhinitis, that's really bad and just won't get better with effective, good adherence to those kind of therapies, we will try Atrovent nasal spray, which is drying. And if that helps, I have sometimes referred patients to ear, nose, and throat to get a cryoablation of the posterior nasal nerve to stop the dripping. But, I always evaluate that on a case by case basis, and it's not super common.
Are there any strategies to avoid developing a chronic cough after a cold or other respiratory infection?
Not that I know of. For patients who have known asthma, I definitely tell them to, make sure they're using their inhalers. And if they just use them as needed, to, start them at the start of a cough or a cold to, see if we can decrease the inflammation and prevent the cough from lingering, although there's not great evidence. Otherwise, I mean, the best thing is prevention. I mean, for almost the lungs, the lungs are a difficult organ because unlike your heart, your kidney, and your liver, which get to sit protected in your body, the lungs are getting exposed to everything all the time. And for most respiratory diseases like asthma and COPD, really the only good things that are protective and that have a lot of great evidence are frequent hand washing and getting your vaccines. We now have great vaccines for RSV, pneumonia, flu. And I really encourage my patients to get, and COVID, obviously. So I just really encourage, prevention and as much as possible, again, with very good hand hygiene and making sure you're up to date with all your vaccines. Because unfortunately, once you get it, there's not a lot you can do.
Can secondhand smoke cause coughs to become chronic even when the irritant is gone?
Yes. Like I mentioned, if you get exposed to an irritant and start coughing and you develop that hypersensitivity, even when the irritant is taken away, the cough can keep going. It doesn't matter what started it. And that's when it becomes that more difficult to treat refractory chronic cough or unexplained chronic cough, that often has a very strong nerve hypersensitivity component that we have to address to try and treat the cough.
Are there any risks to long-term inhaler use?
Oh gosh, this is a really good one because this is something I talk to patients about all the time. Yes. So in my practice, my goal is number one, you got to be able to breathe and you got to have a good quality of life. So you need as much medicine as you need to be able to do that. But I think it's important, and we're looking at this more and more, is that, you want to be on the least inhaled steroid possible because there are dose and length dependent effects. The more inhaled steroid you're on for longer, there are potential side effects, including, increased risk for pneumonia, heart disease, and glaucoma, osteoporosis. But so we always try to minimize the amount of inhaled steroids. But again, as a doctor, I have to say, if you need it to breathe and to have a good quality of life and not be coughing all the time, you have to always weigh those risks and benefits.
Do you have any advice for those affected by wildfire smoke?
Oh yeah, I do. We know wildfires with climate change are getting more frequent. We're very lucky in California. We've not in Northern California that we've been spared for the last couple of years because we had several very bad years there. But I talk to all my patients about doing several things to protect themselves with the wildfires. Number one being monitor the air quality. Two really good sources I like are airnow.gov and Purple Air, and both of them help you monitor the air quality. And you really should modify your activities and your outdoor time based on the air quality and use the recommendations that are put out based on whether it's red, orange, or yellow or green. Green, it means the air quality is good, no activity limitations. But once you get into the yellow and orange and red, definitely should be limiting your time outdoors and limiting, your activities. If you exercise, you're going to ventilate more and take in more particulate matter. I recommend everybody when the air quality is poor to use a good fitting KN95 or N95 mask outside. Those are the only ones that are proven to filter out that small 2.5 particulate matter. That's what gets deep down into the lungs. Unfortunately, a surgical mask or other scarf or covering will not do that. And then when you're indoors, I recommend everybody run air purifiers if you can. And if not, at least air conditioning, because at least that'll circulate the air and, keep your windows and doors closed.
Thank you so much, Dr. Eggert, for sharing all this great information.
Of
And
course.
thank you to our audience for joining us and for the great questions. If you'd like additional information or resources, please contact the Stanford Health Library, and we hope we'll see you at our next lecture. Good
Thank
night.
you.